Hope you all had a very nice weekend. We are going to pick up where we left off on Thursday. We're going to continue our discussion on the chapter 28 content, finishing up our structure and function of the renal system. Not a terrible amount of slides left to finish up for chapter 28. And then we will go right into chapter 29, talking about actual renal failure or acute kidney injury. And just to kind of give you a heads up and kind of give you a plan for the rest of this week and then next week. Again, we'll finish up chapter 28 today. We'll get as far into chapter 29 as we can today. I will then do a voiceover PowerPoint for you for any content that we didn't finish up today. And then also for our lecture on Thursday, since I will be unfortunately out of town on Thursday. Then next week, starting a week from today on Monday, we are going to do another one of our group case study days. And to be clear, the plan is, if you look at the end of our chapter 29 content, a lot of the content that we're going to discuss in chapter 29 alterations is sort of through the lens of case studies. So we won't get to all those case studies today. I will do a voiceover for you on those. But then, as a group, we'll come back together next Monday and talk about these case studies sort of as a group. To sort of make sure we're all on the same page, make sure that you understand all of that all those case studies and all the content within those case studies prior to the exam on Thursday. Again, so next Monday will be case study day, but we will get together as a group and discuss the case studies at the end of chapter 29, so that we're all on the same page and that you feel comfortable and confident with that content going into the exam on Thursday. Does that make sense? So again, I will put it in a voiceover for you as well, but we'll be doing it as a group together on Monday as well. So you'll get sort of double duty. And again, the reason I'm sort of hitting it both as a voiceover for you and then coming back together as a group and doing it together is because it's pretty important content. And I want to make sure that we have adequate time for you to sort of digest it, think about it, but then also be together, present together to be able to get any questions answered and to make sure that we're in person able to sort of answer those questions going into the exam on Thursday. Does that make sense? Okay. All right. So that being said, let's pick up right where we left off on Thursday regarding nephron function. Okay. So what were the three functions of the nephron that we finished talking about on Thursday? Do you remember the three major functions, the three major roles of the nephron? Mm-hmm. Filtration? Good. Very good. Filtration, reabsorption, and secretion, right? Those are the three functions that we spent a lot of time together on Thursday discussing. So all of that content that we talked about on Thursday sort of gets summed up right here on this slide for you. Okay, so sort of what you see is the nephron that I drew up on the board here on Thursday, sort of stretched out longitudinally. And then each part of the nephron is sort of delineated on this sort of in a swim lane, right? So you see not only what occurs in each tubule in terms of reabsorption and secretion. Okay, so what's actually occurring in each one of these areas of the nephron. Basically just another way to discuss and another way to sort of in one snapshot look at all those functions that we talked about. The other thing that I want to draw your attention to on this slide is the tonicity within the ducts. So basically how concentrated that filtrate is as it moves through the tubule system, right? And basically the urine, right? The filtrate that eventually becomes urine. How is it in terms of its concentration? What's its sort of tonicity? What's its concentration as it moves through each one of those ducts? Well, obviously, if you see here at the beginning, after it initially gets filtrated out of the Bowman's glomerulus and the Bowman's capsule, and that very first tubule, the proximal tubule, it's pretty isotonic. I mean, it's pretty much the same tonicity as blood, right? But as it moves through those tubules, through the loop of Henle, then the distal tubule, and eventually reaches that collecting duct, after all of that appropriate sort of reabsorption and secretion has occurred that we, again, spent so much time talking about on Thursday, you'll see that, the overall goal, basically, at the end here, up in the collecting tubule, right as it sort of leaves the kidney and gets, flows out of the kidney through the ureter and then into the bladder and out of the body, is that you want that filtrate to be pretty concentrated, right? And what I mean by that is that good? Do we want that urine that leaves the kidney, that's sort of the finished product of the movement through the nephron? Do we want that urine to be concentrated? And not to confuse you, I don't mean concentrated as in like, oh, this patient's dehydrated and their urine's way too concentrated. But what I mean is, do we want it to be, I'm going to sort of answer the question here for you. Do we want it to be this nice, efficient, sort of concentrated filtrate as it leaves the body? Yes, right? That's basically, another way of saying it is that we want all of those toxic substances to be removed. We want to get rid of all that sort of cellular byproduct, cellular metabolic waste product to be removed out of the blood without losing too much fluid, right? We want to be efficient in terms of getting rid of all the toxic waste products, but yet not losing too much fluid and not, undergoing sort of too much fluid loss through that filtration process. Does that make sense? Okay. So I just wanted to sort of make that clear to you, is that yes, by the end of this process, by the time it gets to the collecting tubule, you want to have seen the appropriate amount of both reabsorption and secretion occurring so that what is sort of leaving the kidney is very efficient, it's very concentrated in terms of the waste products, and we're not losing too much water. We're not losing too much fluid at the end of that process. Does that make sense? Okay. All right. So, and basically, another way to sort of say this, sort of sum it up, is that the final adjustment in urine compositions are made, especially there at that distal tubule and at that collecting tubule, that collecting duct, according to our body's needs, right? So if more water needs to get lost because the person's sort of, fluid volume overloaded, then the kidneys will adjust and they'll make sure they get rid of that excess water. If the body is dehydrated, it's here in this distal tubule and this collecting duct where the body will sense that and hold on to some of that excess fluid. So it's very efficient, it's very smart in terms of what actually gets lost as urine. And this slide basically says exactly that. Yes, we know that most of the water sort of adjustment and the water reabsorption occurs in that loop of Henle, but again, it also sort of does its final checks and balances, if you will, in those distal and collecting tubules. And again, the normal kidney, and what I mean by normal kidney is that the healthy, sort of non-diseased kidney alters urine osmolality to reflect the fluid needs of the body, which I just said. So concentration in those sort of more distal sites, like the distal tubule and the collecting tubule, that concentration depends on increasing solute concentration in the renal medullary interstitium. So if the kidney, basically other way to say that is that if the kidney senses that there is increasing solute concentration going on, in the blood itself, the kidneys are going to hold on to more urine and try to sort of dilute that serum. It also senses it by the passage of filtrate through the collecting ducts and through the concentrated sort of interstitial fluid in the kidneys. And then obviously there is some hormonal control of how and when the kidneys know to either hold on to excess fluid or let it go. And that's through obviously the presence of antidiuretic hormone and some of the other hormones we're going to talk about here. Again, what I really want you to understand from this slide is that through these different sort of factors, the distal parts of the nephron know. They're smart. They're very intelligent in terms of knowing how much fluid to let go and how much fluid to hold on to, depending on the overall sort of needs of the serum in the body. Does that make sense to you? Okay. Final checks and balance. Okay, so in that sort of same vein of discussing sort of normal sort of nephron function and hormones, let's talk very briefly about some of these hormones. Now again, the last unit of the entire year is endocrine, and we will talk more specifically about each one of these hormones. But again, I can't discuss kidney function without at least mentioning them here in this content chapter. So, antidiuretic hormone. We know that the concentration of urine, again, how much fluid is held onto or how much fluid is let go of in the kidneys, is controlled by antidiuretic hormone. So just by the name itself, antidiuretic hormone, what does it tell you that that hormone does? What function does it have in the nephron? It antidiuresis, right? So to diurese means to lose large amounts of fluid. So it's the opposite of that. It's going to hold on to that water. So it increases water permeability and reabsorption in that last segment of the distal tubule and the collecting duct. So it's going to reabsorb a lot of the water content that's in that filtrate about to be lost as urine, and it says, whoa, 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 wait, we need that water back up in the blood. We need it in the serum. And it reabsorbs that excess water back up into the serum. So it causes antidiuresis. You don't lose large amounts of water through your urine because of antidiuretic hormone. And again, to be clear, antidiuretic hormone controls specifically water permeability. As opposed to aldosterone, and again, we're going to talk a lot about the renin-angiotensin-aldosterone system when we talk about endocrine. But for purposes for today, aldosterone stimulates the epithelial cells of the distal tubule and the collecting duct to reabsorb sodium. And then, because it reabsorbs sodium into the tubules, water follows. Again, so antidiuretic hormone is specifically water. Aldosterone reabsorbs sodium, which ends up also reabsorbing water. Okay. Why? When is aldosterone stimulated? What's going on in the body when the body senses that more water needs to be reabsorbed into the tubules or into the blood from the tubules? What sort of is the trigger for aldosterone holding on to more water? Yeah, you remember? Yes, low blood pressure. Specifically, the kidneys sensing low volume of blood getting to them. When the kidneys sense that there is a low perfusion, there is low blood volume getting to the kidneys, it triggers the renin-angiotensin-aldosterone system to reabsorb that sodium and thus water back up into the vasculature. Yes?
So to be clear, it's not the blood that's flowing through by the tubules, it's the blood that's perfusing
to the kidney itself. Okay. Yes. To be clear, the kidneys sense specifically if there is a low volume getting to it, period. So like, for example, if there is a stenosis of the renal artery that's actually blocking blood flow getting to the kidneys, that's a perfect example of how when the kidneys may kick in that renin-angiotensin-aldosterone system and try to get more blood flow to that actual organ itself. Mm-hmm. Different. They're different receptors because there's a different function, but it's the same sort of thing. It's that positive feedback sensing whether or not they're getting what they need. Yes. Yes, exactly. Different receptors, but same overall sort of negative, feedback loop. Okay. So, so aldosterone works because it senses there's a decreased blood volume and decreased blood pressure getting to the kidneys, and therefore increases the reabsorption of water to try to help with that overall volume problem. Now, you might have been sort of familiar with ADH and aldosterone from your previous sort of courses. The one that you may not be as familiar with is this last one on the screen, atrial natriuretic peptide. It's secreted actually from cells in the right atrium of the heart. And that is stimulated when, as you see here on the screen, right atrial pressure, so the amount of blood getting into the right atrium, when that pressure rises, it actually inhibits, it turns off the renin-angiotensin-aldosterone system. And then it relaxes the vascular smooth muscle, it inhibits sodium and water reabsorption by the kidney tubules. Why? Why, if the right side of the heart senses an increase in load, an increase in volume, would there need to be some sort of system to sort of turn off the renin-angiotensin-aldosterone system? Why would that be, clinically, sort of pathophysiologically speaking? Decrease the pressure, decrease the volume, right? So basically, the atrial natriuretic peptide, you can sort of think is basically the opposite, the antidote, if you will, of the renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system gets kicked in when the system denotes a lack of volume, a lack of blood pressure. The atrial natriuretic peptide kicks in when it senses an over volume, right? And it sort of turns off that reabsorption sort of mechanism and inhibits sodium and water absorption by the kidney tubules. So again, to be clear, think about aldosterone and the atrial natriuretic peptide as basically opposites, as basically antidotes of themselves. Does that make sense? Okay. So those are some of the hormones when in sort of discussion of the relationship with nephron function. We're going to talk about a few other renal hormones in just a second, but before I move on to that, I want to just quickly discuss this whole issue of the use of diuretics, especially looking at nephron function and tubule function. So we know that diuretics are really any agent that enhances the flow of urine, and to really say it more clinically, it's best to say it that it interferes with renal sodium reabsorption and obviously then reduces extracellular fluid volume. So it allows for excess volume, excess fluid, water to be lost. So that being said, it treats excessive blood volume conditions, right? It treats any sort of condition in which there is there's over volume in the system. So give me some examples of when diuretics would be helpful. What kind of conditions are a volume overload kind of conditions that diuretics would help? Heart failure, CHF, very good. Any sort of edematous situation, and CHF's the perfect one for that example. Anything else that you can think of? Say that again. Hypertension, very good, exactly. Decrease, get rid of some of that volume, good. Cirrhosis, again, because we know, especially we have that very sort of localized type of edema in cirrhosis when we're talking about ascites. So it helped decrease and get rid of some of that fluid, good. Good. And nephrotic syndrome, which we haven't talked about yet, but we will talk about it specifically with the pediatric consideration of kidneys. Good. So, again, commonly used to treat any type of fluid volume overload, any fluid volume excess, because it gets rid of that excess volume. It allows for, or shall I say, it blocks reabsorption of the water from the tubules to get back into the body. It blocks that, and you just urinate it out. Good. Very good. And then last but not least, a couple other things I want to just quickly mention regarding renal hormones and sort of control of the kidneys with hormones. Another thing that you may not be super familiar with is urodilatin. It is also a hormone that is produced by those distal parts of the nephron, the distal tubule and the collecting ducts, when there is increased circulating volume and increased blood pressure. Again, so it also inhibits sodium and water reabsorption in the collecting ducts and leads to sort of diuresis as well. But again, just wanted to kind of sort of quickly mention that in conjunction with some of the other things that inhibit sodium and water reabsorption. Yeah. It depends on what the underlying cause is of that pulmonary edema. Obviously, if it's, a more pulmonary reason for the edema, perhaps not. But if there's just a backup in fluid in the lungs because of just sort of an overall generalized fluid volume overload in the system, then perhaps it may be helpful. Yeah, good question. Okay, so that was urodilatin, also a hormone that inhibits sodium and water reabsorption in the tubules. And then vitamin D. Now, I promised you on Thursday we would talk just very little bit about the relationship of vitamin D with kidneys, and here it is. So, under normal circumstances, healthy kidneys are very rich with vitamin D receptors. And why that's important is that they play a very major sort of active role in turning vitamin D that we sort of get from UV, from our diet, etc. It turns vitamin D into its activated form. And we know that activated vitamin D is very helpful and very necessary for the absorption and the balance of calcium and phosphate in the body. So that's why vitamin D is so helpful in terms of our bone health, because it helps balance calcium and phosphate. What happens in situations when those kidneys are not healthy, or when you've got some type of either acute or more chronic renal disease or renal failure, is that when the kidneys fail, the ability to activate vitamin D is now lost. You don't have those healthy receptors sort of noting that vitamin D presence and then activating it. So what happens is, without activated vitamin D to control that calcium and phosphate levels in the blood, parathormone, and again, we'll talk more specifically about this when we talk about endocrine, but parathormone, the parathyroid, and then the hormone that the parathyroid secretes, parathormone, will try to overcompensate by this lack of activated vitamin D, and calcium and phosphate levels will go completely out of whack and wonky in the blood. So you'll see really crazy levels of calcium and crazy levels of phosphate in patients with some type of renal failure because of the way that these vitamin D receptors are not there to sort of activate vitamin D. So we know that all endocrine function usually normally under sort of a negative feedback loop, right? And when you have this loss of this negative feedback loop with the loss of vitamin D receptors, you get really crazy serum lab values of calcium and phosphate. And then obviously you start messing up the health of the bones as well. So I just want to mention that here, and we'll talk more about that when we talk about some of the actual manifestations of kidney disease. And then last but not least, erythropoietin. I'm not going to spend a lot of time on this because we've discussed this a lot already. But again, the oxygen-sensing erythropoietin-producing cells are located in the cortex in the tissue of the kidney. And we know that it stimulates bone marrow to produce red blood cells in response to tissue hypoxia. We've talked about that already. But again, it is a renal hormone, and I wanted to discuss it here today. Okay? All right. So, that being said, you can sort of see now how if you have decreased renal function, therefore you have decreased erythropoietin sort of production. And what do you think would be very, very common to see in patients with specifically chronic kidney disease? Profound anemia. I cannot tell you how many chronic kidney failure patients I've seen come into the ER that are just, their H&H is in the toilet. Sick patients already because they have chronic kidney disease, and now they're, extremely anemic and having all of those issues and manifestations of profound anemia as well. So again, hopefully now you can sort of understand the relationship between kidney failure and anemia. All right. So that kind of ends our discussion regarding nephron and kidney function in general. That's all well and good, right? It's all great that you can understand this relationship between hormones and nephron function. It's all wonderful that you can understand sort of what gets reabsorbed and what gets secreted along the flow of filtrate through the nephron that we talked about on the board on Thursday. That's great. But does any of it matter if you can't sort of apply it to your patient clinically in the bed? No, right? It's great that you understand where sodium's reabsorbed or what's secreted in the collecting, in the distal tubules, but what does that actually mean, right? What does that actually look like in our patients in clinical or in your future nursing career, right? We have to try to bring this all together clinically now. And how do we do that? As always, through lab values, right? What does it look like? What do these substances that are supposed to get filtered or secreted or reabsorbed in these tubules look like in the serum if something's not working correctly, right? And that's how we're going to do it. We're going to do that by looking at lab values. We're going to try to bring all of what we talked about this morning already and also on Thursday, bring it together clinically and sort of be able to sort of look at a patient and look at their labs and be able to apply that to what we've talked about already. So tests, clinical labs of renal function. Okay. First and foremost, you probably know this already just from the clinical and the time that you've had already with patients, is one of the major sort of lab values we look at in IDing renal function is BUN, blood urea nitrogen. What is that? What's blood urea nitrogen? How does it get into the blood in the first place? Sorry? It's not, well, right, but how does it even get in the blood even before it's supposed to be filtered? Yeah, it's a cellular, metabolism byproduct sort of thing. It's a waste product, right? And it builds up in the blood until the blood gets filtered through the kidneys, and you're supposed to lose that BUN as the blood gets filtered through the kidneys and then is excreted out through our urine. So, normal range that we should see of BUN any time we look at someone's serum should be about 10 to 30. It shouldn't really be higher than that. If it's higher than 10 to 30, we're looking at it not being properly filtered out of the kidneys, right? So BUN, most commonly used to identify the presence of renal problems, and there's your normal range for you. However, I will tell you that BUN can also be affected by other things like the protein intake of your patient. BUN can be affected by fever. It can be affected by steroid use. So, even though we look at BUN to sort of identify renal function, we even more specifically look at creatinine. Creatinine is more specific, even more so than BUN, in looking at renal function. Again, creatinine is also a waste product that's produced by muscle breakdown, by cellular sort of metabolic activity. And creatinine is almost all of the creatinine in our blood is almost always excreted by the kidney. So there really shouldn't be much creatinine left behind in our blood because most of it should be gotten rid of through the kidney. So the normal range for creatinine is pretty low. It should be really between about 0.5 to 1.5 is the value of creatinine that you should see under healthy normal circumstances. And again, creatinine is more of a reliable lab value for kidney function than BUN because it specifically looks at tubular function. So if there's something wrong with the tubules of the nephron, you're going to see creatinine go up because it's very specific to tubular function. Okay? More helpful because it's more specific than even BUN. Okay? Now, that being said, there should be sort of a normal ratio, so to speak, between BUN and creatinine, and that should be, under normal circumstances, about 10 to 1. Okay? So normal BUN creatinine ratio should be about 10 to 1. I know you don't care about that right now, but you will in a little bit. So keep that in mind, right? Normal BUN creatinine ratio is 10 to 1. Any questions about BUN and creatinine before we move on to some other lab values? Okay. The next one that you absolutely have to talk about when talking about renal function is potassium. Again, we talked about this already on Thursday, but the kidneys are responsible for excreting the body's potassium, right? And I will honestly tell you that K is one of the body's first electrolytes to become wonky with some sort of renal dysfunction, right? We know that the normal range is about 3.5 to 5. And again, oftentimes, you have so many of these ranges of lab values that you're supposed to know and supposed to memorize. And oftentimes on these really important lab values, I try to just remember like one number, so I don't have to remember a range. I can just remember a number, and if it's close to that, I feel comfortable, and if it's not close to that, I get nervous, right? And K is one of those. So instead of remembering this 3.5 to 5 range, I always think of potassium as 4. So 4 is the magic number for K. If it's around 4, we're okay, right? If it's not too close to 4, like looking at 6 or 7, get nervous and grab an EKG machine, right? So that's kind of how I remember K. K should be around 4, the magic number of 4. And then another lab that you may not be as familiar with when talking about renal function is bicarbonate. Most patients with renal failure are in metabolic acidosis, and that's usually because one of the reasons is because they have extremely low bicarb. Under normal circumstances, the kidneys regulate bicarb, and oftentimes the bicarb cannot get reabsorbed from the tubules back up into the blood in some type of renal failure, and so you lose a lot of bicarb through the tubular filtrate in renal function, and they usually have low bicarb in renal function, or in renal failure. So the normal range for bicarbonate is 22 to 26. It is not abnormal in someone with renal dysfunction to see bicarb much lower than that. Again, because they're losing it all out through their tubules and it's not getting reabsorbed from the tubules back into the blood in renal failure. So bicarb is also very, very helpful in looking at renal function. And why would someone be metabolically acidotic if their bicarb is low? Right, exactly, because bicarb is a base, right? And if you have lost a lot of basic, in talking about your pH, if you've lost a lot of base, you're going to be acidotic. Good. All right. Another, last but not least, couple of tests here regarding renal function is the GFR. And we talked about this already when we talked about the amount of blood getting sort of filtered through the glomerulus. Again, it is the amount of blood filtered by the glomerulus at any given time. Normal is about 125 mils per minute. Okay, so a normal GFR is 125 mils per minute. Again, it measures the kidney's ability to filter and remove waste products by that initial, basically that initial start of filtration in the glomerulus. We talked about that already. Again, remember, this glomerular filtration rate, this glomerular filtrate, is the start of urine, right? So if you've got some sort of problem with that filtration going on in the glomerulus, we're already talking about abnormal urine production, right? And that's because that is the start of urine. Good. All right. Any questions about those lab tests? They will become infinitely important to you, I promise. Yeah. Yes, you can. Yes, you can. But the lab value I'm giving you on the screen is serum, is what your creatinine should be in your blood. And the BUN. All of this is talking about serum lab values, to be clear. All these lab tests that I just talked about on all these screens is serum lab values. So if you're drawing someone's blood. Good question. All right. Yeah, another question? Yeah.
Okay, I was just curious about something with the GFR.
Yes.
For KU, when they run the labs, they only show if it's below 60.
They only show if the lab value is below 60? Yeah, in the serum.
Normal is above 60, which is interesting because you have it 25.
No, normal is about 125. Now, the reason that they're going to show it below 60 or not, and actually some labs are going to do 60, some are going to do closer to like somewhere between 60 and 90, is because really when you're talking about a GFR at 90, anywhere between sort of 90 and 60 or below, that's when we're really starting to talk about alterations in kidney function. So that's the lab values that we're most concerned about. Anytime sort of that or higher, we're really not all that concerned. We're not going to address it in terms of kidney failure. No, and we're going to talk about that. You have to lose, like, is it 70% of your nephrons before you even start to really get into sort of renal failure. You've got to lose a large chunk of your nephrons before you start to see abnormalities in health, basically, and that's why. Good question. All right, so last couple of slides here for chapter 28, discussing both pediatric and then aging and renal function. So quickly here, pediatric renal function, we know that kids have a decreased ability to remove excess water and solutes. We also know that they have decreased concentrating of their urine ability. So again, their concentration effort in that distal tubule and in that collecting tubule is not as good in the pediatric population. They also have a very narrow margin for fluid and electrolyte imbalance. So it's kind of a double-edged sword there. They have decreased concentrating ability, yet they're also more sensitive and have a narrower margin for fluid and electrolyte balance. So it's something really sort of careful that you have to watch with the pediatric population, especially when you're talking about kids being sort of in a sort of dehydrating conditions or things like that. They're more prone to fluid and electrolyte imbalances because of their sort of not as efficient function of their kidneys yet. And that being said, they're also, because of that decreased concentrating ability, they're at increased risk of drug toxicity or sort of drug overdose because their kidneys just don't filter it out as efficiently as we as adults do. Anyone in the pediatric clinicals right now know that how you have sort of like specific dosing instructions for kids, like per weight, like per kilogram, milligrams per kilogram? You don't just give them, one sort of dosage like you do with adults. Like almost everybody gets, 40 milligrams of Lasix, right, as an adult. You don't just give a sort of overall dosage to kids. You have to actually do the calculation of their weight because of their not quite as efficient kidneys and their risk for drug toxicity. So there is very specific pediatric dosing based on weight in kids because of this. And then when talking about aging and renal function, here are some of the changes that you see in the kidneys with the elderly population. You see a decrease in renal blood flow. Therefore, you're going to see a decrease in the glomerular filtration rate. So we're talking about issues with altered sodium and water balance. You're also going to see the numbers, and this is normal, right? You're going to see the number of nephrons sort of decrease due to sort of vascular changes in that in those capillaries and perfusion changes to those capillaries. Their response to acid-base changes are delayed. They also have an increased risk for drug toxicity. Again, because of their lack of GFR, they're decreasing nephron function. And you're also going to see with them alterations in thirst and sort of water intake as well. So again, the two biggies that I would sort of make sure that you sort of focus on for this slide of the aged is that the elderly metabolize drugs differently and that's why they have an increased risk for drug toxicity. And that goes hand in hand with, because the fact that their number of nephrons are actually decreased. Their number of filtrating function is gone, right? So because of that, it's not abnormal at all for elderly patients to have way more sort of weird, funky behaviors associated with some medications because of their decreased renal function. There are specific drugs that you just have to be really, really careful with elderly populations because there is sort of a buildup of that drug level and they start acting crazy. Anyone know any of these medications that I'm talking about? Anyone have any experience with giving a medication to an elderly patient and because of their decreased renal function, they sort of respond to this drug differently and kind of have some weird behavioral changes? Anyone have this happen to them in clinical? Yeah?
Couldn't it just be like general anesthesia?
General anesthesia can certainly do that. Yep. There are some pain medications like narcotics that can actually cause some sort of weird, funky behaviors in elderly population because of their decreased filtering capabilities. And then another one that you may not think of, but I think of it, is Benadryl. Has anyone had an elderly patient get Benadryl? Wow. I've actually had a patient one time in the ER who came in for, sort of like a allergic reaction kind of situation. Very intelligent, very sort of leader of her community kind of person, very well respected in her community. She and I had some really good sort of conversations as I was getting her started in the ER. Very, very intelligent, very sharp, elderly lady. Gave her the normal dose of Benadryl again for this allergic reaction. Come back in. Wow. I mean, crawling over the bed rails, talking to people who were dead, picking at bugs in the air. I mean, literally like 5 minutes ago, this woman was having very intellectual conversations with me, and now she's like psychotic. And it literally was because of this Benadryl and her decreased ability to sort of filter it, and therefore you have sort of this drug toxicity build up. And it had everything to do with, her aged kidneys and her inability to sort of filter and metabolize drugs correctly. So that's just a really good example of how you can see renal function decline and sort of what that means in terms of drug metabolism and all sorts of other sort of checks and balances, so to speak, nephrotically speaking. Okay, any questions about that chapter before we move now into chapter 29? Okay, so done with that. Chapter 29. Okay, so we have finished now talking about all the important sort of key functions of the kidney, more specifically all the key functions of the nephron. And now we're going to move into talking about alterations in the adult population of renal function. And what we're going to sort of focus on specifically for our purposes in this class is acute kidney injury and more chronic renal failure. So we're going to talk about two different things. First, we're going to talk about acute kidney injury, and then we're going to talk about chronic renal failure. Okay? So here we go. Here are your objectives for chapter 29. And let's start first with AKI, acute kidney injury. So first of all, I'm going to tell you right now that sort of the definition of acute kidney injury is what you see here on the screen. Sudden, rapid deterioration of renal function associated with azotemia and oliguria. Now, I want to sort of be clear here. When I'm talking about acute kidney injury, I am talking about an injury that can happen to anyone's kidneys. These could be perfectly normal, healthy, functioning people. And for some reason, they've had a sudden, rapid deterioration of renal function. And with that, you will see azotemia and oliguria. Now, what is azotemia? What's that term mean? Exactly. Elevated BUN and creatinine, basically accumulation of nitrogen waste products like your BUN, and then also creatinine in the blood. And you're also going to see oliguria. What's oliguria? Decreased voiding, decreased urine output. That's right. Based on like a 2-liter intake a day of water, of fluid. Normal normal urination per day should be about 15 to 1600 mils per day. Other ranges you might hear would be a little bit broader, like 800 to 2000 mils per day. So when I'm talking about oliguria, I'm talking about profound decrease in urine output, like less than 400 mils per day. That's what I mean by oliguria. Now, yeah, I can write them on the board too. Oh my gosh, I forgot my markers on my desk. Shoot. Normal would be like 15 to 16. Another range that you might see would be even broader than that, like 800 to 2000. And the oliguria that I'm talking about here would be like less than 400. Okay. So what causes this? What causes this acute kidney injury, this azotemia and this oliguria? Well, most oftentimes, acute kidney injury is going to be sort of associated or secondary to anything that may cause hypotension, that may cause hypovolemia, or that would actually be sort of nephrotoxic, meaning causing damage or death or destruction to the nephrons themselves. Okay? And we're going to talk about specific reasons for why each one of those may sort of be the case. Okay? So, give me some examples first before we move into more specific reasons. Anyone know of any sort of nephrotoxic substances that you have to be really careful of in terms of kidney function? Say that again? NSAIDs, perhaps. NSAIDs are metabolized and sort of excreted through the kidneys. Yep. Dyes. IV dyes are huge. Very nephrotoxic. Very hard on those nephrons. Good. And the other one? Antibiotics. Not all antibiotics, but one specific family of antibiotics that's very nephrotoxic are the aminoglycosides. Those are your sort of very hard-hitting, what they call sort of empirical, broad-spectrum antibiotics. They are very, very, very hard on the kidneys. These are like your mycins, like your gentamicin, vancomycin, tobramycin, right? The aminoglycosides, they are extremely nephrotoxic. You have to be very, very careful with aminoglycoside use. Good. Because they are nephrotoxic. Okay. But that being said, again, acute kidney injury is going to be most often due to or secondary to hypotension, hypovolemia. Why would hypotension or hypovolemia, you think, cause some injury to the kidneys? Reduces your GFR. Basically, reduces the amount of volume, reduces the amount of blood getting to those kidneys. And that's not good, right? That's going to cause decreased kidney function. If you can't get blood to the kidneys, how are the kidneys going to filter out that blood and remove the waste product, right? Can't. If there's no blood getting there, the kidney can't do its job. And you're going to see that sort of acute kidney injury. So that being said, there are three reasons pathophysiologically for acute kidney injury. And we're going to talk about each one of these specifically. However, one reason is a pre-renal reason. And what I mean by these is that as we're talking about either a pre-renal reason, an intra-renal reason, or a post-renal reason for acute kidney injury, I'm talking about it in terms of the flow of blood and therefore the flow of urine through that process. Is it a problem with blood even getting to the kidney? That's going to be your pre-renal reason for acute kidney injury. Is there a problem with inside the kidney itself? That's going to be an intra-renal reason for acute kidney injury. Or is there a problem after the kidney in terms of the flow? Is there a problem here in the post-renal sort of area? So like, is there a problem in the ureter, or is there a problem in the bladder causing a problem with urinary flow? So let's talk about each one of these specifically. The first one, pre-renal. This is talking about a perfusion problem to the kidney. There is a lack of blood flow even getting to the kidney in the first place. So it's a pre-renal problem. It's a problem before the kidney even starts, right? And here are some reasons for why there is a perfusion problem to the kidneys. Maybe it's an absolute decrease in blood volume, as we've already mentioned. Maybe this person is a trauma patient who's hemorrhaged most of their blood content out onto the sidewalk, right? Or maybe this is an extremely dehydrated patient that has pretty widespread volume depletion overall. Either way, there's an absolute decrease in blood volume. Therefore, there's an absolute decrease in the amount of blood even getting to the kidneys through that renal artery. Okay? That's an absolute decrease in blood volume. There's also another reason, a relative decrease in blood volume. So a relative decrease would be, okay, the person hasn't necessarily hemorrhaged out all of their blood, or they're not so volume depleted because of dehydration, but perhaps that fluid is sitting somewhere else in the body, not in the vasculature, therefore still not getting to the kidney. So these would be like your third spacing kind of things, right? So your edema, because of CHF, right? All that fluid sitting in their, into their interstitial space. Or cirrhosis, all that fluid is sitting in their abdominal cavity with ascites, and therefore the fluid's not in their vasculature, therefore not getting to the kidneys. Yeah? Sure, absolutely. A burn would be another great reason because of that third spacing of all that fluid outside of the vasculature. If you don't have fluid in your vessels, you're not getting fluid to the kidneys, right? No matter if they've got all that fluid in their body, if it's not in the vessels, it doesn't matter. Yes, very good, very true. Other reasons for why there's a lack of blood flow or a lack of perfusion to the kidney could be just an occlusion or stenosis of the renal artery, therefore blocking blood flow getting to the kidney. And there are also some medications like ACE inhibitors and things like that that are sort of more of a reason for a hemodynamic form that just kind of reroutes or decreases the amount of blood actually getting to the kidney. So any of these reasons, either an absolute decrease in blood volume, a relative decrease in blood volume, an occlusion of blood to the kidney, or more hemodynamic forms, are going to cause an acute kidney injury because basically the way I want you to think of a pre-renal acute kidney injury is the kidney is just drying out. It's not getting its adequate blood flow. It's not getting adequate perfusion, and it's drying out. So, given that fact, what do you think the treatment for a pre-renal acute kidney injury is? Fluids. Hydration. Hydrate that dried out kidney, right? Fix the underlying problem. Get the hydration status back up. If it's because of hemorrhage, give them blood. If it's because of dehydration, give them IV fluids. If it's because of a occlusion or stenosis of that renal artery, open the renal artery up with a stent. Fix the underlying problem. And most times that cause is going to be because of some sort of lack of fluid. So the big sort of main reason, or main treatment, so to speak, for pre-renal reasons for AKI is giving fluids. A big normal saline fluid challenge, right? So identify quickly the reason and prevent further drying. And basically an increase in volume getting to the kidneys is going to equal increased perfusion, and you're going to fix that pre-renal reason for acute kidney injury. Does that make sense? Again, to be clear, these acute kidney injury reasons that we're talking about in general, acute kidney injury is reversible and it's treatable. And in this case, for pre-renal reasons, that's how you treat it. You hydrate that kidney. You get volume back to the kidney. Yeah?
So in a patient with like heart failure or something,
Yeah.
You're spacing and then it gets more influence.
I like it. Good. I was going to bring that up. Very good. She said, so in these patients with like a relative decrease in blood volume, like a CHF situation or a cirrhosis or a burn, that kind of thing, where you've got a relative decrease in blood volume, if you try to fix someone's pre-renal reason for kidney failure who's got CHF by slamming them with fluids, is that the adequate treatment? No. Right. So that's why I said initially you have to figure out what the reason is for this pre-renal and fix the underlying problem. Good. I like that. So it's not always, don't just assume because the kidney is drying out that the fix is always slamming them with IV fluid. Look at what their underlying problem is for why they have pre-renal and address that underlying problem. Now, most times it's going to be a dehydration sort of lack of perfusion problem, and you will give IV fluids. In these cases, that's not the case though. Good. I like the way you're thinking. You're putting those pieces together. Ah, good. What would you do? Much more complicated, right? You have to basically fix these issues, which how easy is that to do? It's not. So oftentimes you're going to see these kinds of patients go into more profound chronic kidney problems because you just can't simply fix these like you can these. Yeah, Very good. I like the way you're thinking. This is not a patient who, because they have lack of blood flow to their kidneys because of CHF, that you just slam them with fluid. So they're much more complicated. And I like how you're thinking that you have to start to think about, okay, how do we fix these underlying problems? Much more complicated. Good. Very good. All right, so that's pre-renal. Now, the next example is an intra-renal problem. So now, what I'm talking about is that there's not a problem before you get to the kidney. This isn't an issue with blood flow to the kidney. This is actually a problem in the kidney. So this is like a problem with the tubules, with the nephron itself. So that being said, probably the most complicated form of acute kidney injury is the intrarenal problem. The prerenal, I would tell you, is probably the most common reason for acute kidney injury. Intrarenal is probably the most complicated reason. Why do you think that might be? Why would an intrarenal sort of nephron problem be more complicated than like a prerenal problem? What do you think? It's not a quick fix, so to speak, as prerenal, right? You can't just fix the underlying problem because we're talking about an actual problem with the tubules now. So it could be a vascular reason. So there could be some vasculitis or some inflammation of the vessels and the capillaries in and around those nephrons in general. You could have some issues with malignant hypertension. So people who have hypertension that is not sort of corrected or they're not compliant with their hypertension treatment can have damage done to those capillaries in and around the nephron. So there can be a vascular reason for problems with the nephron. You can also see acute glomerular nephritis, which is just sort of inflammation of the glomerulus itself. Usually you'll see this sort of post-infectious, where you actually sort of see inflammation of the glomerulus itself. You can see some acute interstitial nephritis. So again, inflammation of the nephron, oftentimes damaged because of drugs. Okay? So here is your really good example of those analgesics or those antibiotics that actually damage the tubules themselves, right? This is where your nephrotoxic substances come in. And then you can also see a tubular necrosis because of some sort of ischemic or nephrotoxic reason to the tubules there as well. But either way, no matter any of these reasons, be it vascular, be it glomerular nephritis, be it sort of necrosis of the tubules, either way, any of these reasons causes an intrarenal problem and therefore causes acute kidney injury. It causes problems. So it can be caused by disease or injury within the kidney tissue itself. Now, we fixed prerenal by treating the underlying problem and most of the time giving fluids. How do you think we treat this? How do we turn this type of acute kidney injury around? That's why I said it's way more complicated, right? Supportive care, watching I&Os really closely. This is a kind of patient who may need to temporarily be put on dialysis while you let this damage to the tubules sort of run its course. Again, I will still say that technically an intrarenal problem for acute kidney injury can still be temporary. It can still be reversible, but it is much more complicated to treat. It is much more complicated to turn around. And again, the reason for that is that these damaged tubular epithelium no longer is able to do all of those functions that we talked about on Thursday. They're no longer able to reabsorb. They're no longer able to excrete. They're no longer able to secrete. All those functions that we talked about on Thursday, they can't do because they are fundamentally damaged, right? And so therefore you're seeing an acute kidney injury. You're seeing all those problems with that BUN and creatinine rising and all of those issues because the nephrons just aren't working. Any questions with intrarenal problems? Yeah. Mm-hmm. You mean, is there actually like an occlusion in the glomerulus itself? I would honestly put that in as sort of maybe like a pre-renal problem because you're probably going to impede the amount of blood getting to that kidney before it even gets there, like in the renal artery and things like that. This is more of an issue with the function of the tubules. So we're talking about the ability to absorb, the ability to secrete. So it's more of a function with tubules and less of a problem with function of blood flow. Does that answer your question? Okay. So this is a tubular problem. This is a sort of tubular problem as opposed to blood flow problem. Does that make sense? Okay. So treating this is supportive care, like eyes and nose, things like that, dialysis if needed on a temporary basis, etc. Okay? Now, if prerenal was the most common and intrarenal is the most complicated, I would say that postrenal are sort of the easiest kind, so to speak, of acute kidney injury. This is going to be a problem post-renal, after the kidney, in terms of the flow of the filtrate, the flow of the urine. So now usually what you're seeing here, most commonly as a reason for a post-renal reason for acute kidney injury, is some type of obstruction or damage to the ureter. So, or some sort of block in flow of the urine out of the kidneys and out of the body. So this could be because of like BPH, benign product hypertrophy, prostatic hypertrophy, or prostate cancer itself that sort of causes an enlargement of that prostate, which then occludes that flow of urine out of the body, and it backs up into the bladder and then backs up into the ureters and then backs up into the kidneys. Calculi, what's calculi? Stone, right? Maybe a kidney stone that gets blocked, sort of jammed up here in the ureter and doesn't allow for proper flow of urine out of that kidney, or maybe trauma to the ureter itself. Now, why would an obstruction in the ureter and backflow of urine up into the ureter and then up into the kidneys cause a problem? I'm hearing murmurs. Those tubules in the nephron are meant to drain, right? They're meant to filter, and they're meant to drain that waste product out of the kidney. When you've got a backup of fluid in those tubules because of a backup in the kidneys from the ureter, you're talking about reabsorption stops due to that backup and due to that reflux of fluid back up into those tubules. If your tubules are all congested, full of fluid that won't drain out, how is proper function of that nephron going to occur? Because they get all dilated and sort of overextended from all that fluid building up? It's not, right? You're going to see a major decrease in reabsorption and filtration in the kidneys when you've got all this excess fluid backing up and refluxing back up into those kidneys. So, if that's the definition of post-renal reasons for acute kidney injury, how do you think you fix this? Remove the obstruction. Fix that prostatic hypertrophy. Remove that calculi. Whatever it may be, get that obstruction out of the way. Remove the roadblock. Allow for proper drainage of urine, and you've fixed the problem. Okay? So that is post-renal. Remove the obstruction. That's the easiest kind of acute kidney injury because it's the easiest to fix. You just remove the obstruction. Okay? So those are the three examples. You've got pre, intra, and post-renal reasons for why you have acute kidney injury. Now, how do we know? Someone comes in, their BUN's out of whack, you can tell that their kidney function is declining. How do we know the reason? How can we diagnose which of those things it is? Is it pre, intra, or post? Well, obviously getting a very careful history and talking to the patient, getting a good sort of understanding of what's been going on, what medications have they been on, what injuries have they had recently, et cetera, et cetera. Thorough a physical exam. Now here's where it starts to get tricky. An appropriate ultrasound and radiological study could help you diagnose acute kidney injury if it's which kind? Post-renal. Good. Why would an ultrasound or some type of radiological study be helpful if it's a post-renal problem? Because you can see the obstruction. You can very easily on an ultrasound see, calculi, a kidney stone sitting there in that ureter, right? So an ultrasound is going to help you rule in a post-renal problem. Now, what if you do an ultrasound and it all looks fine? There's no obstruction post-renally speaking. Well, you've ruled out the post. Now we're looking at either it's a pre or an intrarenal problem. And that's when you're going to have to start looking now at very sort of careful, judicious interpretation of lab data. You can actually look at some of their lab values that we've talked about already from chapter 28 and help diagnose if it's a pre or an intrarenal. So let's talk about that. Let's talk about how to decipher and how to diagnose. You're now going to be diagnosticians, okay? You're going to help me diagnose whether it's a pre or an intrarenal problem. Okay, so this is a very busy slide in terms of a diagnostic approach to acute kidney injury. And all of these are specific gravity, osmolality, etc., is talking to you about, now to be clear, this is talking to you about lab values that you would see in the urine. So I'm talking about specific gravity of the urine, osmolality of the urine, etc. This is just kind of a good sort of FYI for you, this whole chart. The thing that I really want you to understand, and is certainly more than an FYI, is this very last row. This BUN and creatinine ratio. I mentioned this already, didn't I? That you will care about this 10-to-1 BUN creatinine ratio. Here's why. Here's when you're going to start to care. Okay, so let's look at this. In a pre-renal problem for acute kidney injury, you're seeing a serum, now we're talking about blood here at the bottom, serum BUN creatinine ratio of greater than 20-to-1. Let me tell you why. Remember what I said about the BUN being sort of this general lab that's going to be elevated if there's any type of renal problem? I will tell you right now, because it's less specific, that the BUN is going to be high anytime there's something going on in the kidneys, right? So it's going to be elevated if it's a pre-renal problem, and it's going to be elevated if it's an intra-renal problem. As opposed to, what did I tell you about creatinine? It's more specific. And it's more specifically looking at tubular function. So in a pre-renal problem, you will see the BUN rise because it's a problem with the kidney. The BUN's always going to rise. However, the creatinine may rise a little, but not very dramatically. Why? Why would the creatinine not rise all that dramatically in a pre-renal problem? Is there anything wrong with the tubules themselves in a pre-renal problem? Is there disease or death or necrosis of the tubular sort of structure with a pre-renal problem? No. Remember I said a pre-renal problem is just sort of lack of blood flow to the kidney, right? There's nothing structurally wrong with the tubules in the nephron, right? It's just that there's not enough blood getting to the kidney. There's just not enough blood to be filtered, right? So creatinine level is not going to rise all that much because it's specific to tubular function. There's nothing wrong with the tubules in pre-renal failure or pre-renal kidney injury. Therefore, the creatinine is not going to rise that much. So BUN is going to go up, 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 up. Creatinine is going to maybe bump a little, but there's nothing wrong with the tubules, so it's not going to go that high. And what's it going to do to that BUN creatinine ratio? It's going to make it much broader, right? The BUN is going to go up, but the creatinine is not going to go up that much, so you're going to see like BUN go high, like 20, 30, 40, 50, 60. But the creatinine is not going to go much over its normal 1.5, right? So the BUN creatinine ratio is going to be greater than 20-to-1. Now, with intrinsic renal failure, you're going to see the BUN go high because BUN always goes high if there's something wrong with the kidneys. But now an intrarenal problem, intrinsic or intrarenal, the creatinine is also going to go up because why? There's something actually wrong with the tubules now in an intrarenal problem. So both BUN and creatinine are going to go up together in an intrarenal problem. So they both may elevate, they both may be high, but because they're both going high, the ratio is going to be kind of normal, right? Does that make sense? Yes? Okay. It's going to make more sense when we do a case study in just a second. But again, to be clear, BUN is always going to go high. Creatinine is only going to go high if it's an intrarenal problem because there's something intrinsically wrong with the tubules, okay? So in the pre-renal problem, if you see a high BUN and pretty normal creatinine, you're going to have a BUN creatinine ratio of greater than 20, and that's going to be an indicator that there's probably a pre-renal problem. as opposed to an intrarenal problem, the ratio may look kind of normal, like less than 20-1, maybe closer to 10-1 like it should, but that's only because both of them have gone high, and they're sort of an equal ratio at being elevated, okay? We'll talk more about that yeah. Yes. 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 Both of these can reverse itself. Both of these are reversible if you have prompt treatment of whatever that underlying problem is. And I really cannot say that sort of strong enough, that all of these things we've talked about, pre, intra, or post, all of these things are temporary and reversible if you act quickly, if you fix that underlying problem. Now, any of these, if you ignore them, any of these reasons, if you ignore these things, they can move into sort of more chronic, sort of permanent kidney damage, and that's when you're starting to talk about chronic kidney failure or chronic kidney disease. Does that make sense? Okay. Yes. Yeah. Yes. 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 So hepatorenal syndrome or hepatorenal reasons for acute kidney injury is a perfect example of pre-renal, and of those choices that I gave you of pre-renal, what would that be an example of? What's that? Relative, right, because you have all that fluid sitting, and I gave the example of cirrhosis for a relative reason as well. You've got all this fluid sitting in the abdomen with ascites, therefore it's not in the vessels. That means it's not getting to the kidneys, and the kidney is drying out. Perfect. Does that make sense for you? Good. Right. Same reason for why she would be hypotensive is the same reason for why she's not getting enough fluid to her kidneys, because all that fluid's sitting in her stomach, in her abdominal cavity, and not in her vessels to create a blood pressure, and therefore not getting to the organs. Does that make sense? Great. You're putting it together. It's coming together. Good job. Very, very, very good. Okay. So, no matter what the reason, no matter if it's pre, intra, or post, whatever the reason is for acute kidney injury, you're going to see the same pathophysiology occur in the patient, okay? And there's sort of 4 stages of acute kidney injury. The first stage is the onset, or the sort of the initiating stage. And this is really the time between when you have the actual insult to the nephron, the time between that and when signs and symptoms in the patient actually occur. So until then, they're asymptomatic, right? Now, stage 2 is the oliguric phase. Now, this is going to last several weeks. It can be quite long. It can last 1 to 2 weeks. And you're really going to see it within a week or so, 7 days or so, of that causative event. So, in the situation that we just talked about, a patient with, renal hepatic syndrome, where they're not getting enough blood to their kidneys because it's all sitting in their abdominal cavity because of liver problems. It could be the time in which that fluid volume deficit in their vessels has gotten so bad, there's such a low volume in their vessels, that could be the causative event, right? So you could start to see some symptoms, some oliguria, within 7 days of that causative event. And the reason that you see oliguria is because you've got a decreased GFR, right? You've got a decreased filtration, a decreased beginning process of the start of urine, and therefore you're not going to see urine. They're not going to be making urine, and they're going to be oliguric, right? So what you see here is they're unable to sort of get rid of that fluid, right? So what kinds of things are you, as clinicians, going to be concerned about in a patient who is not urinating, and a patient who is holding on to all of that excess fluid and not getting that fluid filtered out through their kidneys and therefore out of their body as urine? What kind of things are you concerned about? What kinds of things are you looking at and monitoring for in these oliguric patients? What do you think? Electrolyte imbalances, good. Specifically, which one would get pretty out of whack if you have all of this excess fluid being held in and on board? Okay, potassium is probably going to get out of whack, and there's another one, sodium. what's going to be happening with sodium? Is this person going to be hyponatremic or hypernatremic in terms of their serum value? Hypo, because they're holding in all of this fluid and it's diluting the concentration of sodium in their serum, right? Does that make sense to you? Okay, so you're going to see hyponatremia. You're going to see increased K, probably because they're not secreting it out back through the, from the blood out into the tubules to be urinated out. Are you going to see a fluid volume excess or a fluid volume deficit in terms of edema and things like that? Excess, right? Because they're holding on to all that fluid. They're not peeing. They're oliguric. And then what do you think is going to happen to their blood pressure if they're holding on to all this fluid? Hypertensive, right, exactly. So these are all the things that would be sort of monitoring this patient in this oliguric phase for, because basically of the lack of urination, the lack of getting rid of that fluid through their kidneys. Good. Very good. Now, if you do not intervene here in this oliguric phase, and the kidney injury is allowed to sort of progress, this is where at this stage, at this oliguric phase, is where we're going to start, if you don't turn around that underlying problem, this is where you're going to start to see more permanent sort of chronic injury and damage to the kidneys, right? If you don't intervene here, you're going to start to see more non-reversible damage to the kidneys. But usually here in this initial symptomatic oliguric phase of acute kidney injury is where you intervene, right? And you turn that causative, that sort of underlying cause around. When you do, you're going to move into the diuretic phase. Okay, so now you've fixed that problem. You have gotten more blood flow to the kidneys, if it's a pre-renal problem. You've fixed that interstitial tubular dysfunction, if it's an intra-renal problem. Or you've removed that calculi in the ureter, if it's a post-renal problem, and you've allowed for now proper drainage of urine out of the kidneys into the ureters. So what you're going to now see, once you've kind of started to recover, so to speak, is that now you're not going to be oliguric anymore. Now you're going to be entering into a diuretic phase. And this can last for a long time as well, several weeks, as you see here. And so what you may see is that when you kind of turn that underlying problem around and you sort of fix that problem, the kidneys are going to sort of regain their ability to excrete waste. The problem is that they have not retained or sort of regained their ability to concentrate the urine yet. So yes, they're starting to excrete waste, but they're not very good at concentrating it and making it efficient. And so you're going to see large, massive amounts of urine lost during this diuretic phase. So massive fluid and electrolyte losses. So now what are you concerned about? Now what kinds of things are you monitoring a patient in the diuretic phase for? What kinds of things clinically are you watching out for? Hypotension. What else? Dehydration. Good. So now what might their sodium look like? Hypernatremia, because they're losing large volumes of fluid, and their sodium is going to look quite concentrated in their serum without that fluid there. Good. So you're going to see hypotension, issues with their blood pressure being, they're going to be hypotensive. You're going to see hypernatremia. Good. Those are all of those things you're going to see there in that diuretic phase. Good. Now, eventually, if you've sort of turned around that underlying problem, you're going to see for the recovery phase. Eventually, the kidneys are going to sort of regain their ability to not only excrete waste, but concentrate that urine and get that fluid volume sort of back in balance, back in check. Now, I will tell you, though, that there is a small percent, like as you see here on the screen, sort of a third or more of people who will develop some type of renal insufficiency even after they've sort of quote-unquote recovered from acute kidney injury. But that's kind of a small percent. And then even an even smaller percent where they have not turned around that underlying cause in time, and they now have moved into sort of more chronic kidney problems. So 5% or more will require some sort of long-term dialysis, or you've had such profound damage done to the kidneys that they're a candidate for transplant, etc. But again, usually, if turned around in time, acute kidney injury is not a chronic problem, and these people can go back to completely normal kidney function, live completely normal lives. Does that make sense? Okay. Now, this next slide here, prognosis for acute kidney injury. Again, depending on when you turn it around, most people are going to do perfectly fine. However, if you already have sort of an ill patient who then has some type of acute kidney injury, or a patient who that underlying cause is not so easily turned around, like that CHF patient that you talked about at the beginning of the class, or the hepatorenal person who doesn't have enough blood flow to their kidneys because of their liver. Those more complicated reasons for why they're having acute kidney injury can certainly lead to more of a higher mortality rate. So a lot of ICU patients there's an ICU mortality rate for acute kidney injury that can be really high. But again, those are going to be because of those more complicated reasons that it's not easy to turn around that acute kidney injury. Okay, any questions about that in terms of prognosis? Okay, to finish up here this morning, I've got 3 case studies that are going to kind of bring to light and sort of illustrate this whole concept of acute kidney injury. Okay, so let's talk about them. Here's the first one. Okay, so you have Mrs. Peach. She's a 55-year-old female who's admitted to the cardiac care unit and was diagnosed with acute anterior wall MI. Her urine output is 20 cc's an hour. You can see her blood pressure and her heart rate there on the screen. Here's her lab data. Now, of all those things, the only thing I really want you to focus on is her serum BUN and her serum creatinine. So given what you see here on the screen, given not only her labs, but also her sort of case presentation, what type of acute kidney injury do you think she probably has? Say it again. Pre. Why? Okay, so her BUN is high. And her creatinine is not super high. I mean, it's 2.1. It's not super duper high. Do the ratio. What would that ratio be? 30 to 1? Right, exactly. So what does that tell you if the ratio is high? Pre-renal, right? No, it's normal should be 10 to 1. Normal should be 10 to 1. Hers is 30 to 1. So that tells you right there it's a pre-renal problem. Why? What's her pre-renal problem? Yeah, what do you think's going on with her heart? That she's had an acute anterior wall MI. Why do you think, because she is in pre-renal failure, or pre-renal acute kidney injury, why? Okay, look at her blood pressure. Her blood pressure is on the lowish side, but why? She's just had an MI. What do you think her cardiac output's going to be? Good or bad? No. She's had an MI. Her cardiac output, I can guarantee you, is... And she's not pumping out adequate amount of blood out to her organs, right? So this is a pre-renal problem. Is it a relative or an absolute reason? Relative, exactly. So she's probably in a little bit of cardiogenic shock, right? She's got a decreased cardiac output due to her diseased heart, due to her decreased contractility of her heart, and she's not pumping out adequate enough blood out of her heart to get to the kidneys and perfuse that those nephrons, right? So she has a pre-renal reason for acute kidney injury. Any questions about that? Does that make sense to you? Okay. Here's another one. Mrs. Levy. She's a 69-year-old female who's admitted with right upper quadrant pain, nausea, and vomiting. And upon initial presentation to the hospital, her serum BUN and creatinine is normal. She then becomes febrile and hypotensive. They do some blood cultures to see where her possibly this infection's going. Then after they've done the blood cultures, they go ahead and start her on sort of broad spectrum empiric antibiotics. Her blood pressure is stabilized with fluids, and she's ruled out for any sort of cardiac reasons. She's diagnosed with cholecystitis. So anyone know what cholecystitis is? Gallstones. Oftentimes they can sort of inflame and cause an infection. Okay. So several days later, after she started on these antibiotics, her BUN is 50, her creatinine is 5.2, her potassium is 6.1. Again, don't pay so much attention to her urine labs. What type of acute kidney injury is this? Why is it intra? So BUN is high, and look at her creatinine. It's also gone up high, right? So even though they're both abnormal, both her BUN and her creatinine are abnormally high, they've risen together, which gives her almost almost a normal BUN creatinine ratio. I mean, it's almost 10 to 1, right? Even though they're both abnormally high. So that tells you right there that that's an intrarenal problem because her creatinine has also risen, which tells you when creatinine rises, it tells you there's an intratubular problem. What caused this person's intrarenal problem? The empiric antibiotics, those nephrotoxic drugs, have damaged her tubules. Good. So this is a great example of intrarenal acute kidney injury because of a nephrotoxic antibiotic. And that's how she would present both clinically but also her labs. Okay? And then, last but not least, I wonder what kind this is. I'm so transparent, aren't I? Mr. Waters is a 25-year-old who's had kidney failure who received a renal transplant. On day 5, he's discharged with a creatinine of 1.5 and his urine output looks good. But 3 weeks later, post-transplant, he presents with a urine output of 400 cc's a day, and his creatinine is 3. An ultrasound demonstrates marked hydronephrosis, which basically just means a bunch of excess fluid in the kidneys. So hydronephrosis of the transplanted kidney and an obstructing lymphocyte. A lymphocyte is basically just sort of like a pseudocyst that's filled with a lot of lymph fluid, and it's in his ureter. So successful drainage of the lymphocyte results in prompt diuresis, and you basically have fixed that post-renal problem, right? Much more straightforward. You fix the obstruction after the kidney, you allow for proper drainage of that kidney, allow for proper drainage of the urine, and you fixed that acute kidney injury because of a post-renal problem. Does that make sense to you? Okay. Now that you've sort of seen the clinical picture for all 3 of these reasons of acute kidney injury, does that make sense? Good. All right. So we're going to end there. Again, to be clear, I will do a voiceover for, now after this slide, we're going to move into chronic kidney disease. I will do a voiceover on that, and again, it's going to be very much through the lens of a lot of these kinds of case studies. I will also do a voiceover for the content for the pediatric renal function for Thursday. And then on Monday, we will get together after you have done the voiceover for chronic kidney disease. We will get together and discuss those case studies that are going to be in that voiceover as a group so you can sort of make sense of chronic kidney disease. We can discuss it as a group, answer questions for you as a group before we move into the exam next Thursday. All right? All right. Thanks, guys.